Good morning, everyone. We're going to wait just a couple of minutes while a few more people join, and then we'll get started. Okay, we've got a full agenda, so let's go ahead and get started. Thank you, everybody, for being here. I'm sure that we'll have a few more people joining. I don't think David and Tabitha are here yet, but we're going to start with Elizabeth Fankhauser, who's going to be talking to us about what qualifies as a social determinant of health. So take it away, Elizabeth.
All right, awesome. Thank you, Lisa. Let me just share my screen here. There it is. Can everyone see that all right?
Yes, we're seeing, there we go. We can see it now.
Okay, awesome. So hello, my name is Elizabeth Fankhauser. I am the Sooner Start Liaison for the Innovation Project. And today I am going to be talking about what makes an issue a social determinant of health. So a social determinant of health is defined by both the CDC and the World Health Organization as non-medical factors affecting health. The CDC expands on that a little bit by explaining that social determinants of health are things like socioeconomic status and geographic location. And the World Health Organization expands even more to explain that social determinants of health are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. But how do you define what is where we are born, grow, work, live, and age? The CDC further simplifies social determinants of health into 5 categories: education, access, and quality, healthcare and quality, neighborhood and built environment, social and community context, and economic stability. And in the following slides, I'm going to be breaking down each of those and explaining how they affect your health. So the first is education access and quality, which is defined as factors related to the education you receive and how well it supports your individual learning needs, including those related to how your brain works. A few examples of that would be available K through 12 college education and college education. K through 12 learning provides the opportunities in the future and career paths that otherwise would not be available to you, as well as college education. Education quality keeps kids interested in school and available to actually learn things. If the education is not quality, they would not be interested in education and are less likely to have those opportunities in the future that K through 12 and a college education has. Another instance would be early childhood development, which is important because they're able to catch when children are struggling and give parents the tools to help their child earlier in life, which helps them have better health later in life. Another example of a social determinant of health in education access and quality is bullying. Bullying causes a lot of mental stress in children, which can affect their health outcomes and the quality of what kids learn at school. If the kids are bullied in school, they're less likely to have positive outcomes at school. But if we crack down on bullying and make sure that the school is a safe environment, they're more likely to be healthier in the future. Second factor or example of social determinants of health are healthcare and quality, which is defined as factors related to the medical care you receive and how well it can meet all your physical and mental health needs. A further example of this would be health insurance. A lot of people are not able to have health insurance and therefore are less likely to get health problems checked out since they cannot afford medical care. Another example is availability of medical care. If there is no medical care, you obviously can't get cared for. In a lot of rural areas, it is very difficult for people to get the care that they need because there simply is none. Another factor is quality of medical care. If you have good treatment, you have healthier people and people who are more likely to go to the doctor. If you have less quality treatment, you don't get things caught and you are less likely to want to go get things checked out in the future. Another thing that ties in with insurance is the affordability of medical care. Many people simply cannot get treatment that they need because medical care costs so much. And if medical care is more affordable, people are more likely to be healthier. And finally, for healthcare and quality, telehealth and online medical records can help reach those with busy schedules or those who are in more remote areas who would go without treatment otherwise. So more people are able to be covered and get health issues checked out. Next, as part of social determinants of health, are your neighborhood and your built environment. Factors related to your zip code, the specific community you live in, including the resources that support your health and safety. A big part of this is the environment. Climate change and increasing heat and pollution across the world affects people. They're more likely to get heat stroke or have the next air and water quality be poor, which is my next point. If the water and air are polluted from things in the city or climate change, you are more likely to have health issues. Another thing is your housing and basic amenities. If your basic needs are not met, obviously you're going to have more health problems. And if your housing and basic needs are not met, you have higher stress, which affects health and your future outcomes. Another part is your sense of safety and security in your neighborhood. If you don't feel safe, you are more likely to have more stress and also less likely to leave your house for fear or of danger and less likely to go out and get the health care that you might need. Last point in neighborhood and built environment is having walkable and navigable cities. Navigable cities are easier to get people moving, to get people going and active. It is also easier for those with disabilities to travel and be out in the world and get healthcare when needed. Walkable and navigable cities are also associated with a better quality of life and a higher sense of community. Next is our social and community context, which is defined as factors related to your relationships with family, friends, coworkers, and community members. First part of this would be good relationships and social connections. These determine your health because they lead to a wider community to rely on. Happier people equals less stress, which equals better health outcomes for everyone involved. Humans are, after all, social creatures. Next part of this is not just good relationships and social connections like the people at work or people you might meet on the street, but also supportive family and friends. This is very important for terms of healthcare outcomes for adults, but also children as well. If children are supported by their families, they're more likely to grow up and have better health outcomes in the future. Another part of social and community context in terms of social determinants of health is social protections, which might be laws protecting against discrimination. Discrimination overall leads to worse health outcomes, whether that be racism, sexism, homophobia, etc. And the last point is to not just protect against discrimination, but to have people be celebrated with social inclusion and non-discrimination. People being celebrated and included in conversations about identities means that they are overall less stressed and have better health outcomes overall. Finally, we're going to talk about economic stability, which has been mentioned a little bit before in health outcomes, which economic stability is factors related to how much money you earn and how well your income can meet all your family's health and other needs. First part of this would be an income and a livable wage. If you are able to provide for yourself and your family, for example, meet their basic needs and being able to pay for healthcare when necessary, you are more likely to catch health problems when they arise, but also you are less stressed in general, which leads to better health outcomes. Another thing would be your working life conditions. If your work conditions are bad, whether that be through dangerous work conditions on like a construction site or it's simply a stressful work environment, you're going to have bad health. If you have better working life conditions, you are more happy overall and more likely to have better health outcomes. The next would be unemployment and job security. If you can provide for your family for yourself and your family in the instance that you happen to be unemployed, you are less likely to be stressed and more likely to be able to provide for any health needs that might come up. And if you have that job security, you are also more likely to do those very same things. The next part of this would be your job and its benefits, whether or not your job has health insurance or paid time off, for example. If you have health insurance, you are more likely to go to the doctor and get health needs checked out, as mentioned before. But also, if you have that paid time off, you have that time to go get health needs checked out if necessary. And you also have time to take vacations, to spend time with family, spend time out of work. Less stressed means happier and healthier and overall more efficient workers. The last would be retirement. If you can provide for yourself and possibly your family when you reach retirement age, you don't have to keep working. You can get your health needs checked out. You don't have to stress yourself out or force your body beyond its limits while continuing to work, and you are more likely to have better health outcomes overall. Are there any questions? I know that was a lot of information all at once.
Okay, thank you, Elizabeth.
Of course.
Uh, Appreciate that. Now let's go over to Angela Harnden. Uh, Angela is from PCAP, and we had some interesting conversations in some of the rounding calls about um, what she experiences with the clients who come in for services. So, Angela, would you like to talk about some of the things we have been talking about in rounding calls?
Sure, I'd be happy to. Can you hear me okay?
Yes.
Okay, great. Yeah, so I think many of you I've already talked to about PCAP in general, so I'm not doing my normal overview presentation or anything. I don't have a PowerPoint for this, but you know that a lot of you are sending us referrals or thinking about sending us referrals for working with women that are either pregnant or parenting a small child that was exposed to substances while they were pregnant. And, you know, I mean, I think that the overview really just gives you the history of why it came to Oklahoma and kind of the basic outlines of what we do. But what Lisa was wanting me to share about is that, you know, a lot of times when we get the referrals, they may not know exactly why I'm calling them. They may have gotten the referral and talked about a lot of different things in their conversations with you. And so when I call them, they're sometimes really shocked when I ask them the question of, you know, the eligibility criteria, which is if they've used any kind of substances, drugs or alcohol while they were pregnant. And, you know, that's a scary thing to talk about or admit or say out loud. And so it's a very punitive state that we live in, and a lot of it's just really scary. And so when I ask that question to them, many times they aren't expecting it. Sometimes they know why I'm calling and what PCAP is about, but most of the time they don't. They've maybe heard that we just provide a resource like housing, and that's what they're interested in. But I have to explain to them that what qualifies them for this program is their use of drugs or alcohol while they're pregnant. And a lot of times they'll say, no, I did not use drugs or alcohol while I was pregnant. I would never do that, you know. And then when I explain to them that that's okay, you know, it's fine if you don't, if you didn't, that is what qualifies you to be in the program. So if you didn't, then you wouldn't qualify. You wouldn't be eligible and you wouldn't get the service. And so let me just tell you a little bit more about it. And so what I kind of ease them into it. And most of the time they'll lift, you know, they'll let their boundaries down or their guards down a little bit to listen to what we do. So I think, I mean, that's one thing that I do when I first talk to them. But really, and I explain to them that we really help them wherever they are in their journey. And for you all to know this too, there's a lot of barriers for these moms and women. They have a lot of trauma. Their ACEs scores are really high. So they have experienced a lot of trauma, and so things trigger them easily. And so what we do is they may be referred to us when they're actually in treatment or in recovery or not quite ready for any treatment. And that's okay. They don't have to, they can be at any stage in their journey to recovery. They will just meet them where they're at, and we'll address the barriers that are in the way of their success and their recovery. So for example, we set goals with them. We help them set realistic goals so they can see success. They don't always have positive support systems to say, good job, you're doing great. And so we want to make sure that we're the positive influence and encouraging them and showing them how to make realistic goals that where they can see success and then hear that we're proud of them. You know, I mean, a lot of people don't hear that. And so like if they're needing employment, that might be really what they're really focused on, or housing. But one of the problems might be they don't have a driver's license, or they don't have the paperwork that they need to be able to attain those things. So maybe their first goal is to get a driver's license, something as simple as that. But we address all whatever the barriers are for them, we help them navigate whatever their stresses are in their life to try to help them work their way to a more manageable, sustainable, and independent life. And so whatever that might look like. Sometimes they come to us and they may qualify by their child's age or being by their child's age, but they may not be in their care. So DHS might have custody of their child, and that's okay. They would qualify for our program even then, and we would help them in that process. Sometimes they need legal aid services. Maybe they're in the court process. And so what our PCAP case managers do is they would go to court with them and help advocate for them and with them, and like teach them how to advocate for themselves by modeling that. We also like link them to healthcare or behavioral health that they need. So we are the kind of a navigator for all their services and try to figure out what it is that they need and then try to find those resources in the community. That's why it's important for me to talk to all of you too, to know what you provide, because we would likely refer them to your services if they're in that area and it was a good fit for them too. So, and you had services that they could use. So I think that's about what, Lisa, you were wanting me to cover. I don't know if there was anything I missed or if I could go on in a different way or say anything else.
I think you've hit it. Questions from y'all for Angela.
Good morning, Lisa. This is Kathy in Tulsa.
Hi, Kathy.
I have a question for Angela, more of whether she's aware of this or not, because it's a little off the beaten path of our process for referrals. But if a mom that you encounter has had a previous pregnancy that either didn't come to fruition or she could have had intervention in the first 2 or 3 months with DHS, we would still be able to consider her a first-time mom and therefore would qualify for a referral to Children First. I just wanted to throw that out there based on what you were talking about the clients that you see. So, because we don't get every referral that we should. So thank you in advance if you happen to see those to refer to us.
Okay, for sure. And thank you for letting me know that.
Absolutely.
I think my
thanks
case
for
managers
educating
are
me
okay
too. Sorry, Angela, go ahead.
That's okay. I do think that our case managers know that, but I'll definitely share that information with them.
Other questions for Angela or comments? Okay, thank you very much, Angela. We appreciate you taking the time to be with us this morning.
No problem.
Okay, now we're going to switch to talking about legal issues as a social determinant of health. And we have Alexis Thackerton. Is that how you say your name?
Yes, that's how I say my name.
Okay. Okay. Thank you, Alexis. I'm glad you're here.
Good morning.
So, over to you.
Good morning, everybody. My name is Alexis Thackerton. As she mentioned, I am a staff attorney here at Legal Aid, but also the staff attorney for our innovation / MIECHV grant. And so I just wanted to talk to you this morning a little bit about housing issues that our clients are facing, and also just touch on briefly how it's also affecting healthcare and social determinants of health. And I used to be a housing attorney here at LASO, so I kind of know the eviction process very familiarly. I'm very familiar with it, excuse me. In Oklahoma County, an eviction can be very quick, and I don't think many people know how quick it is. If you are late on your rent, for instance, or for another reason, and your landlord is wanting to evict you, they can give you 5 to 10 days notice. They can also file for an eviction at the same time that they give you notice that they are planning to move forward with an eviction, meaning if they give you a notice on Monday, they can also file for an eviction that same Monday. And so long as the court date is 5 to 10 days later than their notice, it can run at the same time. So you can be in court the next week, the next Monday. And typically for a lot of our clients, that's scary because they might have been able to pay rent last month, but now it's July 1st or August 1st, and they're already struggling to pay rent. And they might have been just gotten caught up from the previous month. And so now they're struggling to come up with something. And now they only have 5 to 10 days to come up with that money. When we go to court, if they don't have the money, rental assistance is not a thing really anymore in Oklahoma since the pandemic and Community Cares Partners ran out of money. We have very few and far in between rental assistance options available for clients, meaning they might be able to get assistance with maybe $500, but typically that doesn't cover the full balance of their rent that's owed. And even then, it's a waiting process for the rental assistance. It might take a week, it might take 2. Some tribes are willing to help as well, but they might only be willing to help with first month's rent at a new place and also a deposit. Well, many of our clients aren't behind on a deposit and first month's rent. So now they're mid-lease, so now they're not coming up with options for their rent. And so we typically are stuck between a rock and a hard place when we go to court because we don't have many defenses to their evictions. Sometimes we can come up with some and find some creative ways. Our team is really good at coming up with creative solutions to their problems and working out negotiations. But a lot of our clients, if they don't have the money, can't come up with the money, they are either evicted or we can get them some kind of move out agreement. But that still means you're either down some money that you probably needed to pay for other things, or you're out of your apartment or home in a few short weeks. And if you were to get evicted and that we can't work out something, the sheriff can come out within 48 hours after you're evicted. So what went from 5 days is now 7, potentially 10, depending on when the sheriff comes out. And for a lot of our clients, and I mean, really anybody I think would be stressed to move out of an apartment or a home, pack it all up. And then if you throw some kids in there, having to get them to and from school and then also pack it up, you may not have the money to, a lot of our clients don't have the money to hire movers, even get a U-Haul. They don't have a car that is big enough to move their belongings. And so their belongings get stuck in the apartment. And then that's a whole thing. I mean, we can go down that rabbit hole of what happens after an eviction, but a lot of our clients are struggling when it comes to money. And we were talking about social determinants of health earlier. And I mean, not having a home, I mean, is a social determinant of health. Not being able to, have access to a refrigerator for cold food to feed your children or to feed yourself is also a social determinant of health. A lot of our clients too, some may need access to electricity for their refrigerator for their medication. And so if you don't have a home, I mean, that's also a social determinant of health as well. That also leads into access to, healthcare and things like that. If you need a refrigerator and your electricity just got cut off, for instance, let's say you still have a home, but your electricity was cut off for whatever reason, now you don't have access to your refrigerator, which can also lead to a social determinant of health. I mean, we see that quite a bit, and I know Pilar has helped previously get some of our clients LIHEAP or help them apply for LIHEAP and I believe LIWAP, which is heat and water assistance. I mean, because if you don't have water, how can you bathe yourself? And so we deal with a lot of those issues. We try to help our clients apply for different things like LIHEAP, LIWAP, or at least let them know. If we have rental assistance options available, we try to let our clients know about that. And we try to give our clients as much time as possible, depending on their goals, to help them either find a new place or not have an eviction on your record. Having an eviction on your record, I think all of us here know that is a bar to you finding a new place. You might not have been able to afford the previous one, and now you've got this eviction on your record. Even if you pay it off and don't have the eviction, the filing is still there. It's still on OSCN. So now when apartments or homes or landlords just in general go to look you up, now your name comes up as you had an eviction filing 2 months ago. And so that we see that issue quite a bit as well. Many of our clients are on vouchers, OFA, Oklahoma Housing Finance Agency, and also Oklahoma City Housing Authority are here. 2 options for people to apply for vouchers, but the wait lists are long. Typically, I think one of them, their wait list is closed for now, and the other one, their wait list is like 2 or 3 years long. And so, you know, if you're already struggling to pay rent and you don't have a voucher, I mean, it can make it even worse. And even those who do have vouchers, finding a place with a voucher is still hard. Some landlords may or may not choose to want to have tenants who are on subsidized housing for whatever reason. And so we're finding quite a few of our clients have vouchers to move, maybe have been evicted, or just have vouchers in general and are still not able to find a home to live in. Let's see. This week, just to give you just a general number, this week, about 800 people were facing eviction in Oklahoma County. And that's just typical. That's like a typical week for us. Our housing team here represents people every day at court, and they're at the docket 4 days a week, and we get a strong influx of clients that apply day of, but it's still a barrier because you may not know what next week looks like. A lot of our clients don't, and an eviction can go one way or the other. And so really, all of that is just a big barrier to healthcare access, and also just staying healthy in general. And it's hard for us on the legal side to be able to help because we only have so many resources, and we can't get our clients housed. It's not like we can just push them up on the wait list or have rental assistance options available. That was great when CCP was an option because it kept our clients housed for a lot longer, but just now it's just not an option. So I think I've talked for quite a bit. Does anybody have any questions? I see the chat. Sorry, I wasn't paying.
Oh, that's just Pilar chiming in with what the state network is for being able to look up legal cases.
Oh, yes. Does anybody have any questions for me that I can answer?
Good morning, Alexis. I have a question. Is there, I feel like I remember hearing about something legislatively that might have been trying to get started to assist with housing in Oklahoma, but is there anything on the horizon that will help our families not have to face this short window of opportunity to try to figure out how to keep their housing?
I don't know of any legislation or anything that's on the horizon. I mean, our statutes it's just not tenant friendly, unfortunately. And so until the statutes change, that they're not going to really, there's nothing more that we can do really, unfortunately. And I mean, we just need funding really to keep them housed and to just have more options available to them, unfortunately.
That's kind of what I thought, but I want to make sure I hadn't missed something. Thank you.
Other questions for Alexis? Well, you've really brought it to life, the problems about housing, and it just really weighs on me to know that there are 800 families at any given time facing eviction here in Oklahoma City. That's just an astounding number. So thank you for the work you're doing for these people. And thank you for taking the time to talk to us about your work.
Thank you for having me.
Thank you. Okay, so now let's go to Ariana Betancourt Lopez, and she is going to talk about what she learned from the training that she had mentioned at a previous meeting. The training was put on by Illuminate Colorado, and I wanted to give her a little extra time just to talk about how it might benefit your groups. So off to you, Ariana.
Hi, everyone. Yeah, so we have this training, I think it was like early this year, around April, May, maybe before that. It was brought before because we were trying to figure it out what would be the best ways to support our parent educators during the visits when there are questions or they see some like drug paraphernalia in the home, and there is not much kind of like a structure on what like talking points or what the parent educators can say or they can say, because now the policies say that you can, make a report and be to DHS just because of the parents are are using drugs. So we like having that concern make us to like go outside and try to find who is like providing this information to home visiting. And we got this information about Illuminate Colorado, where they are providing training for parent educators or case workers in general to try to kind of like visualize the information that we need to provide to the parents to make sure that our kids are safe, even though you are using drugs. So the idea of those trainings is first kind of like normalize the conversation, like talk about substance use, because they don't name it substance abuse, but substance use, and try to like have that conversation like parent educators with the families about the use of drugs at the home. And it's based on that conversation that is normal and is safe, and I can just talk to you about it because I included in my visit as a regular conversation, like the same way that we talk about alcohol use, the same way that we talk about the medicines that need to be on the cabinets and the bleach needs to be up. Like we have those conversations, and with the parent as teacher curriculum, we have the conversations on visit too. So if the place to have that conversation is right there, the safety conversation. So what they promote is like having that conversation will help to make their children more safe. So they talk about, first that normalize the conversation, make that conversation fluid and safe so the parents can talk to you and get, feel like they are safe talking to you. And then try to make a plan. Like, okay, so if you are using drugs, so who is taking care of your kids when you are using drugs? So it's like, are all your whatever you are using for your drugs are away from the kids? Like, if you are gonna use drugs, who is gonna go and pick up the kids from school? It's like, okay, so you're using drugs, let's make a plan. So when you are using those drugs, your kids are not in danger. They like have a sitter, like that they can see is your kids when you are using the drugs, or like if you are using drugs, who is gonna pick up the kids? So like make a plan so we make sure the children are safe. The other thing is like, well, having those drugs like out of the range of where the kids are, like trying to lock them. So they give us in the training, which is I thought it was pretty cool. They gave us these bags, and they are lock bags, and they have a zipper with keys. They actually give everybody that do the training, I think maybe 12 to 20 bags. I don't remember how many, but so it would be perfect for a parent educator, so they can have one for each one of their caseload, or just identifying the families that actually need them and give it to them. They are free, but we found that you can actually buy them. No, the one from our choice, so you can buy them, purchase them. I don't know if it's in Amazon, but we find any is at Express. So so the idea is like, okay, so you need to have your medicine, you need to have the whatever you're using, your drugs that you are using, have it in a bag, have it locked and away from the rate of the children. So I think that's like the more general information. If you wanna know more, I just got the link here if you are interested in doing the training. So we really enjoy this training because the Jason, which is the trainer, is amazing. It's a very it's a conversation. The training is a conversation. He make it like really easy to for you to ask questions, to offer guidance. He's amazing. This training is offered almost like monthly. It's like every month they have training. So we have all our parent educators doing the training on August, and at the same time we're gonna have it all together. But you can have it all together. You can just have the link. The training is free, so you can have the chance to do it, on your time, whenever you want. I highly recommend that. And I don't know if you have any questions.
Ariana, one thing I wanted to just add was that they also talked about like the babysitters that you have for your children, or especially like relatives, and they were discussing how often that's a concern for parents, that maybe it's like, yeah, sometimes the kids stay with my sister and brother-in-law or whatever it is. And so just to have those conversations and to empower the parents to have that kind of conversation with other family members. And okay, if my kids are going to be in other locations, how am I making sure that that part of their world is safe? So I think that was another component that was also very helpful, and that we've had some good conversations with families about.
Other questions for Ariana?
Ariana, you said that the training is it has a specific date, right? You have to be, or is it a recording that you can just watch later on? Or is it a specific date when they do the training?
We can't hear you, Ariana.
You can hear me?
Yeah, you just need to talk a little louder. We can hear you a little bit.
Oh, okay, so so the training is not a recording, it's live, but they have different, like they have a monthly training, and you can see in the link that I just put, they have one in like July 30, August 15, that's the one that my team is doing, and one in September. So you can just sign in and you can see the number of spots available. So if you wanna, enroll your whole team, I will, even though if you're gonna do it together, you ask everybody to enroll, because you want to have those bags, because that's a really good, kind of like gift from the training.
Yeah, absolutely.
It's like 4 hours training or 3 or 4 hours. So it's a little bit intense, but it's worth it.
How much does it cost?
It's free.
It's free.
It's
All
free.
right. That's the right price, everybody. That sounds like a great resource for everybody, and it could meet some of your training needs for your organizations. We have a question from Pilar in the chat. How soon after drug use disclosure can a safety plan be established with a parent? Do all home visiting partners assist to create these safety plans with parents?
I think that it has to be something like no, everybody is gonna disclose right away on the second visit, like, yes, I'm offering drugs. I think the conversation needs to be there, even if they disclose or not. So probably to get a disclose is gonna be when the parent educator has been visit the family for quite some time. They have already have that relationship established, and it's gonna be like maybe an opportunity, like maybe the parent educator bring is like, okay, I think that we have now the bonding, enough bonding to have this conversation, and maybe the parent will disclose and get on, say something. I don't think that's a conversation that you had on your first or second visit. But there is questions. I think I don't know for parent as teacher or for MIECHV, we have questions. I think on the PCP form, which is in the first visit, that asks about drug use. I don't think like families will feel confident enough to check that by then, but there is opportunity to do it after when you redo that PCP, because that's an annual form. But
yeah,
I think
you have that establishing the relationship, and LCDA saw that. They had a successful referral to PCAP, but they had been working on this mother for a year to get to that point.
Yeah, it's what Angela was saying, like the parents maybe disclose something to the parent educator make the referrals, but when Angela called them, it's like, no, I didn't say anything. It's like, that's not a conversation that you're gonna have with somebody, it's a conversation, hard to do.
Yeah.
To have a conversation. Yeah.
Well, it sounds like you got a lot out of it, and those bags sound like a great resource or item to be able to provide to families to lock up those drugs to keep them away from the children.
Yeah.
We might want to talk about gun safety sometime along those same lines. All right. Thank you very much, Ariana.
You're welcome.
Now let's switch over to, remember I had thanked everybody in the rounding calls for looking up the information about the stranded referrals, the referrals that appeared only in ETO or only in Unitas. And I wanted to share some of what I've accumulated about this. I've received information back from all but one agency, which needed until the end of the month to get the information to me. So we're still working on putting in the data, but this is showing there were 30 referrals to Sooner Start that only appeared in ETO. There were 18 that appeared in Unitas to Sooner Start. Then there were 52 referrals that we thought were legal related, but a lot of these, we expected a lot of these not to be referrals actually to LASSO. And then there were 34 referrals to LASSO in Unitas that we couldn't find a referral in ETO. And a lot of you have come back, and so when we asked you to check these, a lot of those you agreed, out of 78 out of the 110 referrals that we were looking at here, you agreed that it was only in one system. And there was either a reason for that, or it was just an oversight. For instance, the parent educator forgot to put it in the referral tracking touch point. There were 28 where you said it actually was an ETO and we had not been able to find it. And then there were a few that you said they actually were in Unitas, 4 of them that we hadn't been able to find. And then the reasons for these gaps or this discrepancy, they were all over the place. A common one was the client had declined the referral, so there was no need to put anything into Unitas. That was 20 of them. There were a few, well, there was one, the referral partner said the client wasn't eligible. Another time, there was a client who withdrew the request by the time the referral partner contacted him. The client said, I changed my mind. There were 13 that it was an oversight from the PE and they went ahead and put it into ETO. There was one where the client was already being served. 11 graduated from the program or were dismissed or moved out of the service area, and so you couldn't say what had happened. There were 13 that you identified as being made to a different agency. Like, for instance, one of those legal issues that we found in ETO, commonly, a lot of these 13 were being made to an agency that served victims of domestic violence. And then there were a whole lot with other explanations. And so we're still going to be going through the data there. And then there were 22 clients where you mentioned in your feedback that the client had left the program. There may have been more that had left the program, but those are just the number that had been mentioned. David, is there anything here that you wanted to talk about?
I just want to reiterate your thank you to the group for taking the time and care to go through these numbers with us. This is the least favorite part of our job. I'm sure it's low on your list of priorities too, but we want to make sure the data is as accurate as it can be and that we do a fair job of reflecting the progress that was made over the Learning Collaborative. So again, thank you. We'll do one more round of this. It'll hopefully be a lot shorter near the end of the project, just to make sure that these last few months, again, we're capturing everything that you have poured into this project, beginning to end.
Okay, and David, if you would like to talk about the September learning session, that's our last topic for today. We have 7 minutes left, and you were going to talk about the data to be presented for each PDSA.
Yeah, I have a graph up on the screen that actually Lisa created for one of her current PDSAs, and I think it's a wonderful example of what we're looking for in this final learning session. So Lisa and the team, I think, have communicated this to everybody by now in the rounding call, and I just wanted to clarify and answer any questions that may still exist about what the expectations will be. This falls in line with the comments I just made. That is to say, we want to make sure what you present in the final learning session fairly and comprehensively covers all the progress that you made over the last 18 months. And certainly over the last year, while we've had a live Unitas system and you've had active PDSA projects. One of the things we were lacking for the first phase of PDSA was data. We personally did not have data, so we couldn't create dashboards for you. The analysts are going back and trying to put together dashboards for your first PDSA. And the guidance they received from myself and from Lisa is to at least attempt something like what you see on the screen now, where we have numbers that represent a process measure, a disruptor, and an outcome. In this case, you actually see, Lisa, help me out here, 2 disruptors, I think.
That's right.
1 process and 1 outcome. So yours may look a little different in the end, although so many of these projects are similar. I wouldn't be surprised if your graphs look near identical to what I'm about to review. Over here on the left-hand side, this is a process measure. 193 clients were served during the period of this cycle to date. 3 of those, if I'm interpreting this correctly, completed the uncoped screener. So that's a process measure. Is the uncoped screener being used? Yes, it is. In this particular instance, only with a small fraction of the total. That may be a good thing or bad thing. I don't know. I can't remember what program this is or what the goals are, but it's process data. We want to make sure it's on the screen and that it gets discussed, including why the number is what it is during that final learning session. The two in the middle are disruptors, if I remember correctly. So notice the denominator here happens to be the numerator from the process. So these are the folks that were screened with uncope. On the left-hand side, you see clients that declined a referral, and they had 1 out of those 3. On the right, it's another.
Excuse me, David, could
Yeah.
you expand your screen a little bit? We're getting a question in the chat.
Screenshot here. Let me see. Maybe I can do that.
And Tabitha and David, if you can stick around at the end of the meeting after everybody's left, Angela wants to talk to us. Thank you.
Is that better?
Yes.
Okay. And is there a question you want me to address first?
No, that's all right.
Okay. So this was a disruptor of clients that declined, and then just next to it, we have a disruptor of clients where there was a language barrier. So the uncoped screener, well, not, maybe you could be screened, but if it was a Spanish-speaking client, for instance, we wouldn't be able to refer them to PCAP. So I think that's what this disruptor on the right was capturing. You could have both of these things apply, which in this instance is true. So one of the numerator folks here is also somebody who declined the referral. On the far right, you get the outcome. And in this case, of the 3 that were screened, they did successfully refer a client to PCAP, and I believe that one was even accepted. So yours will look different, and it'll certainly look different if we're not talking about PCAP, and instead we're talking about Sooner Start or LASSO. But at the learning session, we'd like to have a diagram like this for every phase of the PDSA. So the phase where you did concentrate on Sooner Start, the phase where you did concentrate on LASSO, and the phase where you did concentrate on PCAP. It would be acceptable, in fact, maybe encouraged is the term I should use, for the numbers you present on past PDSA cycles to be up to date, to be comprehensive. So if referrals have been coming in for Sooner Start in the last several months, but Sooner Start was your focus for PDSA 1, we would like that diagrammed in the chart. I mean, that's still during this project. And so again, to fairly and comprehensively document and disseminate the successes you've experienced or the progresses you've made, we'd like those numbers to be presented.
The limitation on that is that you haven't had access to your PDSA questions that may be specific to your process and disruptor measures in particular. So, but our goal as the analysts is to have something to show you when we do the rounding calls next month, so that we can show you something like this for each of your PDSAs. Now, the focus, the initial focus of your presentation, however, of course, will be your last PDSA that you're going to be presenting. So this will be at the end to summarize. Now, in sum, here's what we've done, here's what we've learned, here's how our practice has changed.
Yeah, a few words on that for a minute. So you've already given a presentation about the plan and the do phase for your past PDSAs. If you could condense that in the final presentation just as a refresher, maybe just to appease me, but I'm sure others would appreciate it too, that, oh, this is what we did, and here's a reminder of how we did it, and then present the data. That's what we're looking for from these past PDSAs. We will have, or we fully expect to have, some of our sponsor agency representatives at the learning session virtually. So part of what I'm asking for here is that we put our best foot forward with the funders and make sure they have a full understanding of everything that was accomplished during the period of the award.
All right, great. We'll talk more about this during the rounding calls. We only have 1 minute left. David, Tabitha, if you could stay on a minute with Angela and me. Everybody else, thank you so much for your time, and y'all have a good day.
Thank you, you too.